Good morning, everybody. Today we're going to talk about EMS operations, chapter 36. This is kind of a short section. Some of this stuff is very obvious. There will be questions on your state test and your class tests regarding some of these things. So, but like I said, some of it's going to be kind of obvious to you guys, especially those of you who are in a department. Um, you've run calls, you've kind of seen how dispatch works, types of ambulances. Those are the types of things we'll be talking about today. Um, but some of you who are not affiliated with the department, um, really pay attention to these things, and we'll explain how, like I said, dispatch works and types of ambulances and things like that. Right. Operations. So what are we talking about? Like, what is EMS ops? Okay, we're talking about what we do to run the call, kind of the logistics of it, not necessarily patient care things, but just how the call runs. Okay, so EMS ops can be from prepping for the call. This is before the dispatch even comes out. These are things you have to do and know before we're even dispatched to an EMS call. Um, Receiving the call, responding to the call, transferring the patient to the ambulance, and transporting to the hospital, and also on the other end, dropping off the patient at the hospital. How do we do that? Okay. And again, some of you know this stuff, but some of you do not. All right. Preparing. So the United States Department of Transportation has issued specifications for types of ambulances. So we have three types: type 1, type 2, and type 3. Uh, Table 36-1 in your book has the pictures um, of the different ambulances. Use Part 800 in New York. So the DOT has the specifications and the tables. It's under Part 800 in New York. And again, just kind of quick review, we've talked about this before. There's Article 30, which is New York state law that says there shall be ambulances. Part 800, so this is a part within Article 30, specifies exactly how we're going to accomplish that. All right, be familiar with what you have on your ambulances and where they are. And it might behoove you as well to look at your neighboring departments, especially those who frequently call for mutual aid. You might be from Kennedy, for example, and you might be frequently running on Ellington's ambulance or Falconer or whatever. So we all do things a little differently. Part 800 doesn't say where those things have to be in our ambulances. All ambulances are designed a little different compartments in different places. So you may keep your non-rebreathers in cabinet A, and Ellington, just for example, might keep theirs in a compartment D. And when you have a mutual aid call that may be some trauma related and lives are on the line, we don't want to be fumbling around in other people's ambulances. Okay. So on the top left, we have our type 1 ambulance, which basically can be described as a truck chassis. The truck with a blank chassis on the back, and they shove a box onto the back of the chassis. There's no doorway in between the cab in the front and in the back. Okay. Over here on the right would be a type 2 ambulance. It's those little van style. All-Star has a lot of those. I don't know how many they have, but you see mostly what they have are the type 2s. They're really tight in the back. You can't get to both sides of the patient in these. When you're working a cardiac arrest, it makes it very complicated to work in these types of ambulances. But there's pros and cons to all of them. They're probably better fuel mileage and things like that. And then probably the most common type of ambulance that we have in this county, at least, would be in the bottom left-hand corner. This is a type 3. Basically, it's a vehicle that was made to be an ambulance. There's a doorway or a window between the front and the back of the ambulance. And that's mostly what we have around this county. ambulance readiness. I apologize, I'm drinking my morning coffee if you guys can hear that. All right, ambulance readiness. So we should do an inspection on your ambulance. And when should we do our inspections on our ambulance? It kind of depends on, if you're in the paid service, you want to do your shift report. You want to do it before you start your shift, because you personally, if you go out there in an ambulance, and this is for the paid service and for the volunteers, if you go out there in an ambulance responding to a call and you're missing things on your ambulance at maybe no fault of your own, the last person who ran the call didn't replace X, Y, or Z, you personally can be held liable for that. Now, your agency is going to get a fine from the Department of Health because they're inspectors and they're assertive. They're very proactive, I should say, in inspecting ambulances and making sure that we are doing the right thing. You may pull into the hospital and see a Department of Health vehicle sitting there, and they want to do an inspection right now. I mean, after you drop your patient off, of course, but they'll hold you there, and they can do that legally, and make sure that your ambulance is completely stocked as it should. So this is why it's important for us to do our ambulance inspections. Generally speaking, the paid service, you would do an inspection of your ambulance prior to the beginning of the shift, just to make sure you have everything so you are ready to go and you know that you're ready to go. In the volunteer world, I understand, like I told you guys before, I've been in both worlds. It was kind of generally Tuesday nights was truck night for our department. And that's when the ambulance would usually get checked. But I found, as a volunteer, I found that it was very, and no fault of anybody, it's just, it happens. You run down there for a hot call, and you hop in the ambulance, you go, which is, what we do. But then you find things that are missing because the last person didn't replace them. And then we all make mistakes, and that's okay. But we are responsible for what's on that ambulance. So figure out a system that you and your department want to feel comfortable with running this certain way. It would behoove you to have a system in place that after every call, somebody who's in charge of that call, chief officer, lieutenant captain, whatever you guys have for your rank structure, make sure anything that was used off that ambulance gets replaced. Again, at 2 o'clock in the morning, we run a call for whatever, we used a non-rebreather, we're tired, we forgot to put it back. That can get the department fined. That can get, technically, if it's egregious enough and you have a lot of stuff, Department of Health can shut you down where you won't be allowed to run your ambulance. Okay, so these things are very serious. I would really, really encourage you to think about a good way to ensure that your ambulance is always up to par. Okay, I get off my soapbox now. All right, with the engine off, this is just all these things. Let me back up just for a second. All these things in Part 800, there's very specific things, and I would encourage everybody to actually read through Part 800 and see, like, they'll specifically tell you you have to have at least 24 4x4s on your ambulance. They are that specific. Not a handful, not a box, 24. If you have 23, you can get a fine for it. So all of these things have to be functioning. The vehicle itself, not just the stuff we use to carry and transport and treat patients, all this stuff is part of Part 800. The air conditioning and heating system in the ambulance has to be functioning. If your air conditioner goes down, you should put your ambulance out of service, because you have to be able to maintain a temperature of, I think it's 68 degrees in the back of your ambulance. And if it's a hot day and your air conditioning isn't working, you are putting that patient in an uncomfortable situation. And the heat, what if they're coming in for heat stroke or heat exhaustion, which we'll talk about in the next chapter? You can't even cool that patient off because your ambulance isn't working right. So those things are very, very important. wheels, tires, windows and mirrors, door latches and locks, fluids, interior, horn, siren, lights. All these things have to work. All of your lights have to work. If you have one light out in the back, technically you should be out of service. Now I know realistically, sometimes, well, that one LED up in the top corner went out and we ordered the new one. Okay, I understand all of that. I'm not the Department of Health. I'm not the one writing these citations. I'm telling you that they can write you up for those things. Okay, fuel level. We should always keep our fuel full, close to full. Mostly, and there's nothing in Part 800 that says you have to maintain at least a half a tank of fuel at all times. There's nothing like that. Generally speaking, departments have policies in place where you want to stay above a half, maybe even 3/4, fill it up after every run. Figure out what your department does. This is another thing that's very important. You don't know what the next call is going to be. You might be, as recently happened, stuck looking for a missing airplane, and your ambulance is sitting there running for 12 hours while people are out in the woods looking for an airplane. That goes for your fire apparatus as well. But you don't want to be sitting on a scene of an MCI or a big situation where you can't just go get fuel and then all of a sudden you're out of fuel, or you run out of fuel on the way to the hospital. You're in big trouble if that happens. Okay, especially if you have a critical patient in the back and something happens and they die because you ran out of fuel. Not a good day. Okay, so I'm just trying to stress this stuff upon you guys. It's very important to make sure our ambulances are all up to snuff, and not just mechanically, but the stuff on the inside. Okay, so with the engine on, all right, we can check the dash mounted indicators, check our gauges, check the brake pedal, check the parking brake. Are the wipers good? Heating and air, communications equipment. Generally speaking, we do a radio check on Tuesday nights in this county, where everybody's standing by the radios around 7:30. They'll hit the tones for your department. Your siren will go off, your pagers will go off, all that. And then you get on the radio and you say Kennedy 10-4, whatever the case is. But they do a radio check on Tuesday nights. But we also have med radios in our ambulances. We usually have a portable. We usually have a mobile that's mounted in the ambulance. Those don't get checked on Tuesday nights. Just our fire radios do. So it might behoove you too to on your whatever night it is you're doing your truck checks or your ambulance checks, hop on the med radio and say, "This is ambulance 321. Can I have a radio check, please?" And make sure that the communications are working for the med radio as well. Okay. Do you have a backup camera? Most the newer ambulances do. There's probably still a few older ones out there that don't have one. Okay, backup camera, backup alarm. Most ambulances are going to have that. But all of those things, if you have those devices, they have to work. Okay. All right. So that's kind of with the engine on, start it up again. Make sure there's no check engine lights or brake lights on, that kind of stuff. Check our fluids. All that stuff's very important. Okay. Then moving into the patient compartment. Again, like I said, Part 800 specifically lists everything you need for your ambulance. If you develop your own checklist, that I would recommend that as well. We have one at work that we use. Somebody developed a long time ago, and it's to do our inventories and that. Every little piece is on there. Use a checklist, say weekly, daily, whatever checks you want to do. We got 24 4x4s. We got 4 adult non-rebreathers, et cetera, et cetera, et cetera. Use a checklist. Keep that checklist. Store it so that you can prove that you've been checking your ambulance all along. The Department of Health will want to see those things when they do their inspections of your department, because that's something that happens every couple of years. I don't want to say every couple of years. Periodically, I should say. The Department of Health will actually come and check your policies, your procedures. They'll check your ambulance. They'll do all this stuff. Okay, and that's their job. All right. We want to check for. So use a checklist. We're looking for our treatment supplies. Oxygen. That's a big one that I've seen. People don't check the oxygen bottles, and they get into the ambulance and it's empty. That's not good. We should have some spares on the ambulance as well, the small cylinders. But if you get a long transport time, those little bottles don't last very long. You need to have your onboard full, okay? Maybe not full, but close to it. All right, check our AEDs, air splints, bandages, all that stuff, okay? All right, so what's the role of dispatch? Most areas of the United States, 911 is the number to call. It's not actually all of, I think in the United States is the way everything works, the way 911 works. Outside the country, I really can't speak for. But around here, we use 911, okay? And then a call taker will answer the phone, and he's going to say, 911, what's the location of your emergency? If you have any questions about this stuff, by the way, I used to work there. Ron Hassan still works there. Matt Kuhn works there. Evan, one of our instructors, Evan, you guys have met. He works there at dispatch. If you have any specific questions regarding dispatch, please let us know. We've done the job and we kind of understand how it works. So don't be afraid to ask. So anyways, the call taker will take the 911 call. They'll ask questions and assign a priority. So they have a list up there, these flip cards, and they say, and you say, here's my address. I'm saying you're the person calling 911. Person calling 911 says, here's my address, and my grandmother is sick, whatever the case is. And so the call taker is going to ask a whole list of questions, and they're all on flip cards. So you flip to the card that says difficulty breathing, you ask some specific questions, and then the call taker will assign a priority. So in this county, we have BLS standard, BLS priority, and ALS calls. Not to mention car accidents, that's a little different call type, but generally speaking for EMS, we have 3 call types. So based on the answers that the call taker gets, he or she will assign a priority. So BLS standard, BLS priority, or ALS call. All right, the dispatchers can provide pre-arrival instructions. And what we mean by that is if it's cardiac arrest, if there's certain medical things that you can explain to somebody over the phone, the call takers can do that. Generally speaking, when we talk about pre-arrival instructions, we're talking about CPR, cardiac arrest. So the call taker will actually say, are you comfortable with doing CPR? I can explain to you how to do it. And sometimes they say yes, sometimes they say no. It depends. I mean, not everybody's made to do this job. Some people just straight out freak out and they refuse to do CPR on their loved one because they don't want to hurt them. And you can't force it upon them. But if you get a dispatch that says pre-arrival instructions are being given or something to that effect, that means CPR is in progress, and dispatch is telling them how to do CPR. Okay, the call taker, they're gonna dispatch resources. So the way our dispatch works, there are a few seats that just take calls. They don't actually do any dispatching. They'll take the calls, they'll create the call in the computer system, and they send it over to the dispatcher, and the dispatcher will actually send out the units and get on the radio and talk to you. The dispatchers themselves who are on the radios, they'll answer the calls too. So it's kind of whoever answers the phone call. But they're going to dispatch the resources, and they're going to coordinate with other agencies if need be. If you are with Falconer and you need another ambulance, you're going to get on the radio. You're going to say, hey, I need another ambulance from Frewsburg or Kennedy or Gary or whatever, Jamestown, I don't know. And then the dispatcher will say, okay, and they'll get that other agency going. Okay. They're going to ask the exact location, the call taker I'm talking about now. Okay. They're going to ask specific questions. They're going to want to know exactly where you are, which sometimes is a challenge. Callback phone number. They're going to ask, what's the problem? What's the age? What's the gender? Are they conscious? Are they breathing? Okay. Those are the most important questions. I don't know if he's breathing. That happens a lot. We'll go to a lot of unknown if breathing. That's just because they don't know. It's not suggesting that they're not breathing. That's just saying that they don't know. And we go to a lot of calls too that say they come in as unresponsive. To me, as an EMS provider, unresponsive means that person very well might be dead or uh, completely unconscious. Um, so we don't know what's going on. This is like, oh boy, something's going on here with this patient. And then we get there and the person's awake. They're just not responding to the question. So they might have low blood sugar or something to that effect. Um, so just be aware of that. Not every unresponsive call you get is going to be a cardiac arrest. Okay. Operating the ambulance. So what does it take for us to operate the ambulance? Okay. When we're new, we all get excited and we're like, oh, it's a call. Yes, we're going to go save somebody. And your blood pressure increases and your heart rate increases and you're excited. Okay. That's normal. But you have to be able to control that. Okay. You can't hop in the ambulance and be shaking because you're scared. Okay. At least don't convey that to the patient. Okay. We need to go in there calm, confident. Okay. You have to have the ability to perform under stress, and not everybody can do that. There are a lot of stressful situations we end up in, and just keep in mind that if you don't have the mentality to do this, that's okay. It's not for everybody. All right. And again, we all get a little nervous. We all get excited when we're new. If you can't work through that, or eventually you become more calm and confident with your abilities, this might not be the job for you. Okay. And that's okay. Sometimes it just takes getting into it to find out. I know of people who have gotten into it, seen some nasty calls, and said, nope, this isn't for me. Totally fine. No problem. Sometimes we don't know until we see it. Okay. Drugs or alcohol. Okay. Don't do drugs. Don't do alcohol. Do not, for those of you who do drink, don't go on a call if you've had a sip of beer. Okay. Listen, I'm not judging here. Okay. I consume alcohol myself. But what we don't know when we're drinking is how much we stink. When you start running a couple calls, when you're stone cold sober and you smell the booze on somebody else, you start to realize how bad it smells. And when we're drinking, we don't notice how bad we smell. Our breath, it comes out of your pores. The glossy eyes, that kind of stuff. That's really obvious to a stone cold sober person. So if you've had any alcohol, don't go on the call. Don't go on the call. Okay. You do not want to get there. One, you're impaired. So you might not make the right decision. Two, you show up as representing your fire department or your EMS agency smelling like booze. That makes the whole department look bad. Okay. Just don't do it. Okay. Impairing medications. Okay. There's lots of impairing medications out there. We prescribe them frequently by doctors. Pain pills do it. Anxiety medication can affect you like that. Okay. If you're on some kind of medication, you're prescribed it, you're allowed to take it, all that, but you don't feel right, or, those bottles say do not operate heavy machinery when taking this medication. Okay. Probably shouldn't be hopping on the ambulance. Okay. You're allowed to take it. You're not doing anything illegal when you're on that medication, but if you're impaired because of it, it's just as bad as you going there after drinking. Okay. You have to have a valid license. Drive with due regard. So what is due regard? That doesn't mean that we can just blow through every red light and stop sign we see. Okay. We still have to stop. Now, can we go around stopped cars and run through red lights and people get out of your way and it's kind of fun sometimes? Of course, but we still have to do it safely. Okay. Every stop sign, every red light, we still have to stop, because if we don't stop and we blow right through a red light and somebody T-bones into the side of us, guess who's going to be at fault? We are. Now, we're an emergency vehicle, but we weren't driving with due regard, and that's in the vehicle and traffic law. Okay. Stop at the intersections, look all directions, especially with multiple lanes intersections. Look, creep forward, keep looking, have your whoever's riding up there with you, if you're driving, of course, whoever's riding, have them look to the right, you're looking to the left, you both look to the left and the right, your head is on a swivel, okay? Accidents do happen in emergency vehicles. We are going to be at fault if we're running red lights and somebody crashes into us, or we crash into somebody else, of course. Don't drive. Wait a minute here. I don't want to. Yeah, okay. I don't want to get too far off topic here, especially if we're going to talk about it. You don't need to drive 100 miles an hour to a call. Let me back up to the priorities, the EMS call priorities. Okay, BLS standard, BLS priority, ALS calls. Okay. When you get dispatched to a BLS standard call, you will be dispatched via voice, through your pager, through your radio, whatever the case is, and they'll say, ambulance, whatever, respond to a BLS standard call at this address. Standard means there's no life threats going on here. This is probably a stub toe, something to that effect. Somebody who hasn't been feeling well for 4 days. Okay, we do go on those calls, and those are ambulance calls. BLS standard calls, we do not run lights and sirens. Okay, just drive there like you normally would. Stop at all the stoplights. Okay, get to the patient. BLS priority means that there's something potentially life-threatening going on. BLS priorities, we are allowed to run lights and sirens too. And ALS calls, of course, are the most serious. We're going to be running lights and sirens to those. But that doesn't mean we need to drive 100 miles an hour, okay? There's nothing in the law that says you can only drive 3.5 miles an hour over the speed limit. There is no laws as far as the speed goes. However, due regard is a bit subjective, right? So the law says due regard. Were you driving in due regard going 100 miles an hour in a 35 mile an hour zone? No, I would say not. And you're going to get in trouble for that. Your departments will have policies in place. They may have one that says you can't drive more than 5 miles an hour over the speed limit. They might not have that strict of a policy. It's really whatever your departments want to do. But I'm telling you, just drive safely. You don't need to hammer the gas on every single opportunity. You don't put yourselves and the people that you are driving in the back of your ambulance, don't put them at risk. Even when we're running to the hospital, say a cardiac arrest is the most common call that we will drive lights and sirens to the hospital, or a stroke. Couple serious calls. Generally speaking, we drive to the hospital with no lights and sirens for the most part. When driving to the hospital, now you got somebody there's CPR in progress in the back of your ambulance. Stress levels are through the roof. We're all working like, oh, we want to save this person's life. Yes, we do, of course. We want to get there safely. Okay. Drive with due regard no matter what's going on in the back of your ambulance. Okay. Get off my soapbox there for a second. Okay. Warning lights and sirens, when to use and when not to use. We just talked about this. Okay. Those BLS priorities and ALS calls, we can use them. Accidents. All right. What happens if we get in an accident on our way to an EMS call? Guess what? You better stop, get on the radio, say, dispatch another ambulance because I just wrecked. You can probably word it more tactfully than that over the radio, but we have to stop for an accident if we get in an accident. Okay. That doesn't give us the right to just carry on. Even if it's a little fender bender, you still have to stop. Now you have to stop. You're probably going to get a ticket. Not good. Okay. Red lights and stop signs we talked about. Seatbelts. We always wear our seatbelts. I feel like I shouldn't have to say that. Always wear your seatbelt. There's some good ambulance crashes out there where people get real hurt because they're like, I don't need a seatbelt. You should always wear your seatbelt. It's too easy to put on. In fact, they make it hard not to put it on now because there's dingers everywhere. It's kind of annoying, but that's why, because they want you to wear your seatbelt. Okay. And distractions, there's a lot of distractions going on. Okay. We got the radio traffic. You're thinking, okay, I got this information. It sounds like a rollover crash and there's bodies everywhere. Okay. Those things can be very distracting. We're still operating that ambulance. Okay. Try not to get too distracted by all the things going on. Okay. Highway incidents. Highway incident. So we need to block the accident with our apparatus. We have a highway section. We have a chapter on highway safety. So I'm not really going to get into that too much right now. Um, but generally speaking, if we're up on the highway, we want to block the accident with an apparatus. We'll talk more about that in the highway safety section. It's a short section, but it's just kind of some specifics on how to park your vehicles and those types of things. Wear your proper PPE, meaning reflective gear. Okay, cones and flares are good. Stay on the same side of the road as the accident. People start looking, rubbernecking as soon as they see lights. Every single car who's coming up to that accident scene is going to be watching what's going on there. And if you step out from the side of your ambulance, they probably aren't looking at you. They're looking at the scene. Okay, you're going to get smoked. This happens. Actually, I just read an article yesterday. I think it was in Massachusetts. Off-duty nurse stops. Car accident. She stops. She's like, "Oh my gosh, I'm going to try to help this person." She got smoked by a car and died. Don't know the incident. I don't understand what happened in that story. I just read this yesterday. But those things happen. Those things happen to us, even with the PPE on and all that. Okay. You have to be very, very mindful of what's going on around you. Situational awareness when you're up on the highway and any road for that matter. All right. So transferring a patient to the ambulance. This will be a test question. Okay. The definition of packaging. Okay. There'll be a question like when you put your patient on a stretcher and load them into the ambulance, that's called what? And the answer is packaging. We are packaging our patient for transport. Okay. So when we're packaging our patient, we want to cover their patient, especially if they're naked or not fully clothed. Of course, we want to keep them warm if it's cold. Protect their modesty a little bit. Sometimes we end up in places where our patients aren't fully clothed. We don't want to just leave everything out there for everybody to see. Okay. Cover them up. Use all the seat belts, okay, including the shoulder straps. The newer stretchers now have like crisscross for the shoulders. The older style ones, like the ones we have at the college, they go up over the shoulders and they connect across the chest. It's not hard to skip those shoulder straps and say, and they got 3 seat belts on there, good enough. Okay, no, that's the wrong answer. If your stretcher has seatbelts, use them all. You have to use them all. Okay. Once you get into the ambulance, if you have to take one off to get a blood pressure and treat the patient in the back, that's okay. Okay. They should be fully strapped in all the time, but realistically, if you have to make some adjustments, that's okay. You can do that after they're loaded, but we don't want to drop grandma off a stretcher. Okay. Transport. So during our transport, we're going to continue our assessment. We've spent a lot of time on assessment. You guys understand the difference between the primary and the secondary. Generally speaking, our secondary is going to be done in the ambulance, especially those of us with longer transport times. Sometimes we're like, well, let's just get moving and we can really drill down on what's going on here. On the non-critical patients, the secondary assessment is less important, I should say. And then, of course, the serious ones, we want to get them loaded quickly and do the secondary assessment in ambulance as well. All right, positioning the patient, what's comfortable for them, generally the way we need to go. If we're, somebody's in a collar and they're unresponsive, whatever the case is, laying them flat down on their back might not be the most comfortable for them, but sometimes we just kind of have to do what's right for the patient. But generally speaking, we want them to be in a position of comfort, which is usually the Fowler's position. Okay, personal effects. Does your patient need her glasses? Does she need her keys? All right. They don't know how long they're going to the hospital for. And if the patient's stable, enough that we're taking our time, take the time and ask the patient. Now, remember, especially you guys in the volunteer service, these are your community members you're taking into the hospital. These aren't just some strangers. These are potentially your neighbor. So treat them like a neighbor. Do you need your glasses? Do you need your keys? Do you want us to lock your door? Do you want us to make sure the dog's in? Things of that effect, okay? Neighborly things, okay? So once we're all set to transport, everything's set, they're locked in place. Usually we try to get a good set of vitals before we start bouncing down the road in the ambulance, because it's a little harder to get a good set of vitals while the ambulance is moving. Generally speaking, we'll get a good blood pressure, a good set of vitals, and then we'll signal to the driver. We're gonna say, okay, we're ready. And they'll say, you can initiate by saying, all right, we're ready to go, nice and easy. That's kind of the signal to the driver saying, okay, we don't need to go lights and sirens. If this is a serious call, you can say, let's get there quickly, or whatever your communication, whatever you guys want to do, to tell the driver we need to haul to the hospital. Okay. When we're en route to the hospital, of course, at least one EMT needs to be in the back. If there's more people available, it's not a bad idea to have at least 2 people in the back. There has to be at least one EMT. But if somebody else wants to ride with 2, it doesn't hurt to have a second person in the back of the ambulance with you, especially if they're 2 different genders. Maybe it's a young female patient and a male EMT. Those types of situations, generally speaking, we want to have 2 people in the back of the ambulance. If we can't have at least the same gender provider with the patient, just to keep, we're in a litigious world nowadays and weird things happen. By no means am I suggesting that you guys would do anything wrong, but sometimes people get accused of things and we just don't want to be in that situation. So let's try to have at least 2 people in the back of the ambulance when possible. All right, we're going to call our med report. Monitor the ABCs, of course. It's part of your patient assessment. Give the patient info, or gather all the patient info, I should say. Look at your charting software. We still do use paper in the city. Make sure you get all the information you need. Your patient might not be at home when you take them to the hospital. So where do they live? Where does your patient live? And make sure you get that information so you can fully fill out your chart. Okay, and reassess. Okay, here's an example of a med report. Okay, usually with radio communication, we hear it all the time. A lot of guys at work do it too, and across the county and in dispatch, and this is how the cops do it. The cops will say me to you. Okay, any communication class I've ever been in, which was the fire academy, the military, it's always you, this is me. This is how you start your communication. So you'll say, Medcom, this is ambulance 1. Okay, and they'll answer. I say, can I have a patch to the UPMC Chautauqua? Okay, stand by. Okay, and then you start your med report. So you want to make that connection to the hospital, and that's how we do it at UPMC Chautauqua. To be honest with you, the other hospitals, I know some of the Western county fire departments will go to Hammett. There's Westfields out there, Brooks. There's different hospitals. I actually don't know how to communicate with those. So get with your departments. There's a phone number you can call too, but generally speaking, we use the med radio for these types of patches. So we're going to say we have a 67-year-old female, alert and oriented, complaining of a stubbed toe. No pertinent history. We found a broken toenail. We put a Band-Aid on it. Patient says the pain is 15,000 out of 10. Their vital signs are as follows, and we'll be at your facility in approximately 5 minutes. I mean, that's basically a med report. Don't tell a story on the radio. They don't care. They want to know the pertinent information: age, gender, chief complaint, what's going on with the patient. If the patient's in a bad shape, let them know what you did to treat the patient. Patient's on oxygen and we're bagging the patient. That's important for the hospital to know. If it's a stable patient, you can be pretty quick with these. Okay, so then transferring the patient to the ER. Okay, ask the staff what room. UPMC Chautauqua has a TV screen in the back by the ambulance bay. It's not always updated. They're busy people. Okay, so if you walk in and you are not on their screen, that's okay. Just wheel them in. Say to the charge nurse, where do I go? and they'll tell you, continue care until relieved. So just because we're at the hospital, we get the patient moved to their bed. If nobody's in that room, somebody from the staff, nursing staff, you don't leave yet, okay? Hang out with your patient for a few minutes until the nurse comes in. You're going to give a verbal report, which is similar to what your med report was. Oh, this is Mrs. Johnson, and she stubbed her toe and she broke her toenail off, and we put a Band-Aid on it, and she really wants to get an X-ray or something to that effect. Okay. Of course, I'm downplaying. That doesn't always happen. We're not always in there for stub toes. We are in there for critical things sometimes, but make sure you give that good verbal report. Do your documentation, and make sure that the patient gets their personal effects. We have driven off with people's canes and glasses and bag of medication, and we've gotten back to the station and said, oh crap, we have her things. We got to go back down to the hospital. And you need to do it now. I don't care how far away from the hospital you or your station is. Their stuff needs to be brought back to the hospital now. Okay, so just do a quick sweep of your ambulance before you leave the hospital. Quick sweep. Make sure nothing's going on. Make sure you're not missing anything. And then you're good to go. Completing the call. So we want to replace our used equipment. I kind of beat this to death earlier. Don't be the person who doesn't replace the things on the ambulance. Okay. Our sheets and blankets. First disinfect the stretcher. So there's wipes everywhere in the hospital. Wipe down your stretcher real quick, make sure it's disinfected, especially now in the days of COVID. It's probably more important to do so. Clean any body fluids, trash, non-expendable items. Blood pressure cuffs and stethoscopes, guess what? Those get funky sometimes just from being on one call. You might get blood all over it. You might get puke all over it, whatever it is. We're not going to just throw that stuff away unless it's really bad. I mean, I suppose there are situations where we would toss something like that, but generally speaking, those things are cleanable. Clean them up real good so that the next person on the ambulance doesn't have to deal with that. Okay, we're going to radio dispatch. We're clearing the hospital, so we're going to radio dispatch. We're going to say ambulance 123 is back in service, returning to station, and refuel if necessary. Okay. Air rescue. So past years, we would do the Starflight ground school. Starflight no longer exists, unfortunately. STAT is now in there. We don't really have a system for doing an actual ground school, but this is something that we will put together in the class. Just some tips on air rescue stuff. When we need to call for an helicopter, how we put together a landing zone. I will get with Ron and we'll look at the schedule and we will do something. It'll be brief. It won't be like a whole nother chapter or anything like that, or a whole nother night. This is just some important things for you guys to know. Other than that, we are done with chapter 36, and I will see you guys soon.